Hi, everybody. Thank you so much for joining us today for another What's New in Addiction Nursing presentation. And my name is Nicole Cowens. I'll be your moderator today. And just before I introduce our presenters, I just wanted to mention it's wonderful if you have questions or comments that are coming up throughout the presentation. We're going to have some dedicated time after the presenters are finished running through to circle back to those questions. So yeah, keep them in mind and you can be putting them into the chat throughout the presentation. And so we'll get started. So our presentation today is updates related to OAT, Nurse Prescribing Certified Practice. And we have co-presenters. Lisa Noel is a registered nurse currently working as an Indigenous health liaison nurse in Fraser Health. Lisa has experienced personal loss due to the overdose crisis, and it was the catalyst for her interest in pursuing the Addiction Nursing Fellowship Program. And through the fellowship, Lisa's gaining greater understanding of substance use care and resources available for clients and families that she's working with, and looks forward to continuing her work with fellow Indigenous populations after she completes the fellowship. And also Amelia Herrmann is here today, is a registered psychiatric nurse currently working in acute psychiatry in Cranbrook, BC. And Amelia is passionate about supporting clients with mental health and substance use challenges, and future interests in nursing include and research include nurse prescribing and behavior modifications. And in her life, she's very focused on living in the moment. So I want to welcome you both today. Thank you so much.
Thank you. Good day. Today we would like to present the updates to nurse prescribing opiate agonist therapy, abbreviated OAT, nurse prescribing as a certified practice. This will be brought to you by my colleague, a fellow RPN, Amelia Herrmann, and myself, an RN, Lisa Noel. Just to clarify, Amelia or I are not certified nurse prescribers yet, but we do have a nurse prescriber from Vernon who kindly agreed to join us at the end of our presentation to answer questions from the audience. We would like to acknowledge that we are humble guests on the unceded traditional territories of Musqueam, Squamish, and Tsleil-Waututh First Nations. Personally, I am joining you from the traditional and unceded territory of Lecamo First Nation. Next slide. We have no conflicts of interest to declare. Our outline, we will discuss the background, the epidemiology, the relevance and the impact, and finally provide an overview of the nurse prescriber role with further recommendations. And as mentioned, we will have a guest nurse prescriber join us for our Q&A period. Next slide. Our objectives today will focus on comparing the new scope of practice to the old directives. We will describe the role and limitations of a nurse prescriber. We will explore the need for nurse prescribers, and we will look at supports available. We will discuss the education requirements and finally touch on the decision support tool. Next slide. The background. Dr. Perry Kendall declares a public health emergency, and Dr. Bonnie Henry's public health order. The toxic drug supply claims lives and continues to claim lives. OAT is indeed a life-saving treatment. We will shed light on the need for nurse prescribers, and most importantly, we will discuss how nurse prescribers have the unique ability to reach folks that can be easily missed in a medical model. Next slide, please. In 2016, Dr. Perry Kendall declared a public health emergency, which allowed the province to collect detailed data on the toxic drug crisis. That would allow for the creation of targeted interventions. Previously, data was only collected on overdose deaths. Now the collection of detailed data included location, drugs used, how they were taken, and non-fatal overdoses. This data, in turn, can be used to create targeted outreach services bad drug warnings, awareness campaigns, and the distribution of take-home naloxone kits. Next slide, please. In this recent publication, it represents the impact of the toxic drug supply situation in 2023. It illustrates that illegal drug supply remains highly toxic, with fentanyl widespread as both a drug of choice and as a contaminant in other substances. Here, the x-axis represents the year of death, and the y-axis represents the number of deaths per year per 100,000 of population in that given year. As you can see, the number on the yellow dotted line represent the average number of deaths per day in the associated year. The deaths started to decrease in 2019, then COVID happened, and it limited people's access to services. This was also around the time that benzodope came out, and it further complicated some of the existing interventions, such as naloxone, because naloxone does not work on benzos. Next slide, please. In this article, the authors found that retention on OAT was associated with a substantial reduction in the risk of mortality of people with opiate use disorder. Additionally, the protective factor of OAT increased as synthetic opiates, such as fentanyl, became more prevalent. Next slide. In this slide, the x-axis represents the year, and the y-axis shows the standardized mortality ratio on and off OAT. The research illustrates the all-cause standardized mortality ratios on and off OAT from 2010 to 2018. As you can see, between 2010 and 2018, it was observed that substantial increases in the risk of mortality was notable off OAT, whereas the risk of mortality on OAT remained stable. This graph identifies the date of April 1st, 2012 as the first date of overdose in which fentanyl was detected, and the date of April 14, 2016, when the declaration of a public health emergency was released. Next slide, please. In 2020, Dr. Bonnie Henry issued a public health order as a toxic drug supply continued to claim lives. This new order was to help address a lack of access to opiate agonist therapy, particularly in rural and remote locations. Thank you. Under this public health order, one of the changes allowed registered nurses and registered psych nurses to take the training that would allow them to prescribe some OAT to clients with strict parameters. This public health order allowed the nurses with the required additional training to order and interpret diagnostic tests, make a diagnosis of a substance use disorder, prescribe specific drugs, including controlled substances, and refer on to a specialized and primary care services. All of these things must be done for the treatment of a substance use disorder. When the public health order first came out, the college restricted nurses to prescribing Suboxone exclusively. Eventually, it was expanded to include slow-release oral morphine, also known as Cadian, and methadone. The first cohort was completed by 30 nurse prescribers. Next slide. Thank you. This LIP review from 2022 shows evidence that people in rural and remote communities are being disproportionately affected by opiate use, while also struggling with limited access to OAT. This is a common theme that was identified as a barrier, the lack of providers of OAT in rural and remote locations. The authors also highlighted how a holistic community approach was a facilitator of OAT retention in care. I will now be passing the presentation over to my colleague, Amelia. Thank you.
Hello. Okay. So, certified practice is an OAT nurse prescriber. BCCNM now expanded on the public health order and created a certified practice designation for RNs and RPNs to work as nurse prescribers for OAT. This includes a scope of practice, education requirements, as well as standards, limits, and conditions for certified practice. With certified practice, RNs and RPNs can diagnose opioid use disorder and prescribe relevant medications, including OAT, using the decision support tool, as well as ordering relevant lab and diagnostic tests. The move to certified practice has not changed how the existing nurse prescribers operated, and the current nurse prescribers were grandfathered in to have certified practice because the education requirement has not changed. So how has certified practice changed OAT nurse prescribing? Because OAT prescribing is now certified practice, it allows nurses in this role to have some expanded scope of practice, including they can now give orders to other nurses to act on. They can assess via virtual care. They can delegate the assessment of a client in situations where another healthcare professional can do the eyes-on assessment. And they can initiate slow-release oral morphine and methadone. With the new opioid use disorder guidelines, they outline principles of care, and that's incorporated into this certified practice. So the 2023 OUD guidelines incorporates a holistic approach to care by emphasizing various principles that prioritize patient well-being, cultural sensitivity, trauma-informed practices, harm reduction, and comprehensive support systems. These principles aim to guide healthcare providers in delivering effective and inclusive care for individuals with OUD. So I'm just going to kind of go over them a bit. So there's principles including patient-centered care, social determinants of health, anti-racist practices, Indigenous cultural safety and humility, trauma-informed and violence-informed practice, an integrated continuum of care, self-defined recovery and wellness, harm reduction, comprehensive health management, and family and social circle involvement in care. So certified practice, it's one of the more significant changes is that nurse prescribers are now allowed to initiate slow release oral morphine or methadone for a client. The old directive only allowed for restarts after a limited number of missed doses. Otherwise, they would have to be referred to an OAT doctor. This change is significant because it will further lower barriers for our clients to access care. So the updated scope reflects the new OUD guidelines. This is for methadone. So under the new scope of practice, the nurse prescribers, the new scope of practice for nurse prescribers reflects the new OUD guidelines. This is clearly outlined in the updated decision support tool for nurse prescribers. So you can find these on the BCCNM website. They're quite handy. There's another one here. So updated scope to reflect the OUD guidelines for slow release oral morphine with the new certified practice that allows for nurses to do new starts of SROM and methadone. However, the current toxic drug supply that has a high degree of benzocontamination, it can create a difficult situation for nurse prescribers because this may constitute the use of non-prescribed benzos. Fortunately, we have the decision support tool that helps us understand when to refer or consult. So you can see on there, one of the times you would refer or consult is if they're using non-prescribed benzos. So this can kind of complicate things. Selecting OAT decision support tool. With the new OUD guidelines, selecting OAT is a shared decision, as outlined in the decision support tool here. There's an emphasis on retention and treatment, which has informed the new OUD guidelines. They removed the language that presents Suboxone as first line, and they've made it a shared decision, taking into consideration the individual's circumstances, goals, and previous treatment experiences. So the training pathway. To obtain certified practice, the nurse must ensure that their employer will support the training. And then they'll go through a specific training pathway that includes completing the POTS-P course online through UBC, completing a workbook, and then doing in-person preceptorship hours with an approved OAT doctor. The POTS-P course is free, it's online, it's self-paced, it's really well delivered. Even if you don't want to do nurse prescribing, I do recommend it. It's a lovely course. Then getting support from your employer may include things like establishing if there's a need, and then deciding if there will be enough opportunity for you to use that skill in your job in order to maintain the skill. The best place to start is by contacting your health authorities lead. Their contact information is actually on the BCCSU website. There was a suggestion made by a nurse prescriber to me that perhaps a preceptorship could be divided between an OAT doctor and an approved OAT nurse prescriber so that the student can get more experience within their scope. And the relevance of that will come up here in a little bit. So, limitations to nurse prescribers. As with any nursing scope of practice, it can be further limited by the employer or health authority. In this case, one of the limitations put on by health authorities is that nurses cannot write orders for use inside hospitals. This may limit access for clients visiting emergency departments in rural and remote sites where OAT trained doctors are not always available. And then unlike doctors who can prescribe outside the guidelines, if they feel it's indicated, nurses are bound by those guidelines. And so that kind of comes back to where the suggestion was made to split the preceptorship between a doctor and a nurse prescriber, because often those doctors are prescribing outside the guidelines, and that's actually not in our scope. They also cannot order Sublocade at this time and must have an eyes-on assessment, which may limit the ability to provide services via telehealth. So some of the benefits, you get enhanced access for clients. That's like a really big benefit. Nurse prescribers can enhance access in rural locations. And because of the flexibility in the provision of care, they can spend more time with clients if it's indicated. This can potentially give the nurse the advantage when building relationships with clients in a population that can be very challenging to reach. It also allows for outreach into the community, meeting clients where they're at. And I'm hoping that our guest nurse prescriber will kind of speak to that, because he showed me what that looks like and it's very cool. So how health authorities or Interior Health Authority is utilizing virtual care. Interior Health Authority is utilizing virtual care for nurse prescribers to reach some of the smaller communities. I know where I work, they do virtual care for some of the like much smaller towns that are around us, which will help to enhance access for these rural and remote locations. So BC currently has about 190 certified practice OAT nurse prescribers, including Kyle, who's pictured here holding the very first SROM prescription written by BC nurse prescriber. And so I got a little quote from Kyle. He said that working as a nurse prescribers in the community, we have the flexibility to adapt the model of care to meet the needs of the individual where they are at. This enables us to provide life-saving OAT services to clients who may not have otherwise engaged. What supports and resources are available for certified practice OAT nurses? Currently, there's a monthly virtual meeting for nurse prescribers in the province. They support each other and problem solve together. There is also the BC CSU clinician support line. It's available 24/7 for nurses and other service providers within BC. Nurse prescribers can also develop relationships with pharmacies that facilitate dose titrations for clients by having the pharmacist do the eyes-on assessment for the nurse. And then here is information on the addiction support line. So the 24/7 addiction medicine clinician support line provides live in the moment addiction medicine support to physicians, nurse practitioners, nurses, midwives, and pharmacists while they are treating patients. The 24/7 support line will connect healthcare providers to an addiction medicine specialist who has expertise in addiction medicine, including emergency, acute, and community care. The consultation can include support in screening, assessment, treatment, and management of substance use and substance use disorders. This support line is staffed 24 hours a day, 365 days a year to provide rapid response for time-sensitive clinical substance use inquiries. Healthcare providers using the support line must be practicing in British Columbia. That's a question I've had from other people in other provinces, and unfortunately, it's just for BC right now. So a couple of recommendations we had for future opportunities. Sublocade, I think, is the big one. So it's been revolutionary, a revolutionary development in the management of OUD. Hopefully in the future, it will be included in the nurse prescriber scope. And then supporting nurse prescribers in hospital, even in a limited capacity, could potentially improve clients' experience in care and then maybe help relieve some of the burden on admitting doctors. And then that's it. Questions? I'm muting myself.
Thank you so much, Amelia and Lisa. So just opening it up to the audience for any questions. And then let's see, was Kyle able to join us?
He is here. I don't know if Kyle has anything he'd like to add or anything he'd like to say.
Yeah. Sometimes it's helpful, just to hear for other nurses to hear kind of firsthand about nurse prescribers' experience.
Hey, I think I'm here. I'm not sure if I can be heard.
Hi.
Also, sorry, I'm just getting over a cold, so I'm still coughing a bit if I'm trying to talk too much. But yeah, hi, I'm Kyle. I'm a nurse prescriber in Vernon, BC. I've been in my current role for a little over 2 years, coming up on 2.5 years now. And as Amelia mentioned, had the privilege of writing BC's first script for Acadian, which was a really, really cool experience. So great presentation. Thank you, Amelia and Lisa. I don't feel like I really have anything specific to add to it. I feel like you covered the nurse prescribing really well. But I am here if you do have any questions or if you're looking for elaboration on anything.
I will just kind of describe what, like, Kyle took me for outreach when I was with him, and I'll kind of describe what that looks like because I think it's really, really cool. I'm very much about person-centered care, and this is very person-centered. So when I was there was a client that had been started on methadone. Kyle, you'll have to correct me if I'm wrong, but I think I have it. Been started on methadone, but didn't come in for their reassessment for their up titration of their dose. I believe they were just on 40, which was just the starting dose for them. They needed to be reassessed, and they didn't come in. And so we were able to walk to the local shelter and find them there and like do the eyes on assessment and meet them there and assess them in the community. And so that, is that right? Then Kyle, you were able to go and do the dose increase from there.
Yeah, I actually I don't recall that specific situation, but that definitely describes a lot of the work we do here in Vernon. We work in a clinic, a shared care clinic with OAT physicians. So we do have a hybrid model of care where people come to the office for appointments. So then there's myself, the nurse prescriber, and an OAT nurse who's also trained as a prescriber. And we take referrals from the shelter, being one example of people who are wanting to get started on OAT, but really having a hard time accessing service, whether that's physically getting here, having the motivation, dealing with ambivalence. I've had a few clients tell me, and it's really stuck, that it's easier to get fentanyl than it is to get on OAT. People selling drugs are willing to go to the shelter and offer that right there. So the incentive to come in is not always there, even though there is motivation for change. Sometimes if you feel dope sick, it's easier just to take what's right in front of you. So being able to get out there and meet people where they're at and offer the service they're looking for in a similar manner has been wonderful. And I think that's something unique to nursing because we have that flexibility in our practice.
It was like one of the big things that stuck with me that was like, this is really cool that we can do this.
Just wondering too, how have like establishing relationships, for example, with pharmacies and things like that, how has that gone where they're sort of more involved in the circle of care for the client?
Pharmacies, and I'm sure this differs from community to community, but in Vernon, we have a number of really wonderful pharmacies. They're very collaborative, go above and beyond, what would be expected of a pharmacist. The role of nurse prescribing, I feel, really depends heavily on a pharmacist because of some of the limitations in our scope of practice. An example of that is if we have a client who sees our physicians here who misses an appointment, our doctors will often provide a prescription to that client if they can look on PharmaNet and see that they've continued taking their medication. But one of our conditions through our college is that we need to assess that person, whether it's over the phone, virtually, or face-to-face before we can provide that prescription. So here in Vernon, our pharmacists often, if I'm looking for someone and haven't been able to see them, the pharmacist will call me on their cell phone when they're with that client, and I can do a virtual assessment with the client in that moment. Or if the client misses the dose that day, the pharmacist will often say it's a Friday, we don't have weekend coverage. The pharmacist will provide emergency dosing over the weekend to allow time to connect.
Thank you so much for sharing that. Yeah, because they're a really important part of the team. Especially when during the titration phase where we're needing to connect with clients on a more intensive basis potentially and really frequently. So yeah, it's really exciting to hear that's happening. Yeah, we can definitely learn a lot from what you're doing there in Vernon. That's awesome. We've got a couple of questions from the audience. So one is, what are the annual requirements to maintain certification? And is there a number of clients that need to be seen annually?
That is something I did not see but
That's a great
honestly didn't go looking for either. Kyle may be able to answer this.
I'm sorry, I can't. I work as a full-time nurse prescriber, so it's really not even been on my radar. I have no concerns about
Yeah, you're busy.
yeah, I'm nurse prescribing every single day, so I know that I'm maintaining my competency. If I were in a casual position, I would definitely want to be looking at what that is specifically. And I think BCCNM does have some language around it.
Great. I see, Emma, you've raised your hand.
Yeah, I mean, I think this becomes a little bit clearer with certified practice, because there's other examples of like how you maintain your certified practice competency and report on that when you do your annual license. And that doesn't necessarily mean you have to have done a certain amount of that work, but it's like, how are you keeping it up? Like that can be attending communities of practice and like working through cases with other people and like other contact with the work. Because there's certain settings where it may be really important to have someone trained, but the volume is a lot lower. So I work for the First Nations Health Authority, and that's something that comes up there as well. So there's kind of a few ways around it, but it's also a self-assessment too, right? Like if a year went by and you hadn't done it, there's like probably, I would want to, spend a bit more time with a preceptorship or seek some other opportunities, something like that too. So different health authorities also have different self-competency assessments, as well as our BCCNM.
Yeah, thank you so much for mentioning that. I'll give an example too. Like the practice will vary depending on health authorities and the way that in nurse prescribing is being implemented. So for example, in Vancouver Coastal Health, they wanted to have nurses have like a certain amount of prescriptions before they're doing, for example, methadone starts and things like that. And so the practice will sort of vary, and requirements may vary as well, depending on what each health authority's professional practice body is sort of established. And usually within the organization, there's SOPs and things like that to refer to there. So yeah, great questions. We also had another question here from Shyla about can nurse prescribers do their practicum with nurse practitioners? Great question.
There's a list of approved certified OAT doctors. As far as I know, it is just the doctors at this time. But maybe that'll change in the future. I'm not sure. And I don't know what the requirements are to get approved as an OAT doctor either.
Yeah, I know, like so the BCCSU will have a list of prescribers that can support across the province, and then also there may be a prescriber that is working with the team, even if they're not, but they're willing to support the nurse. There's also like ways that can happen as well.
I'm seeing in the chat now, I guess NPs, if they're on the list, but yeah, they have to be approved by, and I don't know who does, like, yeah.
I think that approval happens through the BCCSU, and it's just through an expression of interest. One of our physicians here is on that list, so I did some of my hours with her, and I actually did a part of my hours with a nurse practitioner as well through a separate clinic, and I'd recommend for people in the nurse prescribing path going through this education. If you can do your preceptorship with a couple different people, it's really nice to see different prescribing practices, especially when they come from different backgrounds, as a physician and a nurse practitioner do.
All right, I see there's another question from Sarah in the chat about how many practicum hours are required for certification.
That was answered in the chat.
Membership.
It's 40 hours, yes.
Yeah. Oh, okay, great. And then also just a note about that, that's technically the requirement, but there may be, usually there's additional supports that could be offered as well if needed. I saw somebody else had their hand up here.
There's something in the Q&A.
Oh, here we go. Angelica. Do you want to take your, you can take yourself off mute? Do you have a
So
question?
we just can't have participants unmute
Oh,
at the time. So we just asked if everybody could please put their questions in the chat or the Q&A. That would be great. But there is something in the Q&A box. I see.
sorry, in my chat, I'm just seeing some comments here.
The Q&A is a different box.
Oh, sorry. Oh, great. So we have another question here. With benzo contaminated supply, are nurse prescribers having to escalate care more often? Great question.
It's probably a good question for Kyle.
Yeah, I mean, I can answer this only for myself. So other nurse prescribers in other communities, I couldn't say, but yeah, I would go with yes and no. Like, there's the contamination of benzos alone doesn't mean that as nurse prescribers, we have to escalate our care. Because it is a known contaminant, it's actually quite rare that there aren't benzos in the supply. We are prescribing for people that are using contaminated benzo supply, often in consultation, but not having to actually escalate that. So we're still able to do a lot of the care. The concentration of benzos, certainly in this area, has changed. It's more prevalent in the supply and in higher amounts. And additionally, we're seeing more adverse effects when people are starting to stabilize on OAT and using less street supply. We're seeing complications like agitated deliriums or seizures and increased presentations to the emergency department. So that's definitely an area where we are having to refer more. I find myself even actually sometimes feeling almost a little more nervous with Suboxone prescribing, where we're asking a person to abruptly discontinue their use of fentanyl for a traditional induction, or even with a microdose at day 7 or 10, depending on the schedule. That day where they're abruptly stopping their use of fentanyl, we're seeing more adverse outcomes from the withdrawal from the contaminated benzos. So I've been referring more people to a detox center if their goal is to get onto, to rapidly get onto Suboxone, just so they can do that in a supervised environment.
Thank you. That's a great point. So yeah, just really important for, yeah, all nurses to be really familiar with benzo withdrawal symptoms through stabilization as well. That's great. All right. Were there any more questions from the audience? Okay, another great question. Great. This one is from Sarah. I'd love to hear how nurse prescribers navigate requests for safer supply for like OAT and safe supply.
So for myself in this situation, it's often just a candid conversation or immediacy, just letting that person know, hey, this is what I can offer you today. I'm a nurse working with certified practice in OAT. I'm not able to do safe supply options. Because we work in a shared care clinic, I can offer that that person can either wait and see a physician if they want, or I can get them started on something like methadone and Cadian, and they can come in to see the physician to talk about adding that safe supply at a later date, but at least we can get them started on something right away. Most people are happy to do that, with the plan to come in and talk to the doctor about safe supply. I've had a number of clients that I've actually gotten up to a therapeutic dose of either methadone or Cadian without safe supply because they haven't attended an office-based appointment, and I've just continued their titrations on an outreach model to a point where they're not making that request for the safe supply anymore. So
Amazing. That's exactly why we use OAT. So that's awesome.
Thank you. So one more question from Emma. Lisa and Amelia, did you happen to find any other places or provinces outside of BC where there was nurse OAT prescribing?
I didn't go looking too much for that. I was kind of more focused on BC. I believe there is some potentially in the States, maybe in the East Coast. But as far as Canada, I don't know if they've started anywhere else in Canada. In fact, I believe even Ontario, in this fellowship I've learned in Ontario, they don't even use Cadian at this point, I don't think. So I'm going to assume they don't have nurse prescribers. I could be wrong, but I didn't specifically go looking for that. I don't know if Lisa did.
No, kind of the same. Actually, it was even tough getting some people actually that work in prescribing in other provinces or work with OAT in other provinces to actually have conversations with us. We found a lot of barriers there. No, I didn't find anything formal in other provinces like we have in BC, like a certified practice designation.
I'm sure Emma or Nicole might know more.
Yeah, so we reached out in Ontario. There definitely is interest in pursuing nurse OAT prescribing. They have nurse prescribing in other areas as certified practice, but not OAT yet. So yeah, it will be really, really interesting to see what happens and further information that's going to come out of, formal evaluations and that are done with the BCCSU. And we'll have, a lot to share to support this practice in other places in Canada potentially as well. So that's really, really exciting.
I was
Yeah.
thinking about this because reading about the public health emergency and how that allowed for like more data collection, it made me realize that like we have data on stuff that other provinces may not. And so that may explain why we have different interventions that other provinces don't, because we have the data that shows that we need it.
Mm.
So that might be part of the reason why.
Yeah, interesting point. It's great. Right, I'll just pause there and see if there's any other questions that folks that are joining us virtually. If you have any other questions, pop them in the chat. And then, of course, as always, if you think of something after you want to reach out to us, we really appreciate that. So you're welcome to get in contact with us and our presenters today. And yeah, really. Oh, Emma, you want to jump in again? Yeah, go ahead.
I could always have more questions, and we have time. I'm just curious from Amelia and Lisa and anyone else on the call, knowing that nurse prescribing has been around for a few years, like it's actually been kind of slower on the uptake, I think, than the initial hopes were. Like, what gaps do you see and where do you see some opportunities for more implementation of these rules, either through your own experience or maybe even what you've seen in fellowship placements?
I mean, we kind of touched on the whole, even having some capacity in hospital. I was thinking maybe in the emergency department, or like if you're in a rural site and people are admitted overnight and there's no doctor that's comfortable prescribing, like just continuing someone's community dose until an admitting doctor that is comfortable prescribing OAT can come in, like little things. Yeah, maybe Kyle can speak to it. I don't know. Like, are you busy enough, Kyle, that you think that there's a need for more nurse prescribers in community? Like, I assume there would be, but I don't know what the uptake has been, like if they're overwhelmed or if there's, yeah. I think with the outreach model, you can probably reach more people. I mean, infinitely.
Yeah, I think like all areas of healthcare, there's always need or room for more. We could have more prescribers, certainly. We're only able to reach so many people, and I feel like there's more, nursing interventions we could do to connect with even more, but based on limited resources and time, we do what we can. So as for other areas, yeah, I can't really speak to those. There's certainly like limitations on like we're not able to prescribe for people that are in treatment centers or detox or the hospital, like you mentioned. I'd be a little nervous about doing that, even with a couple of years of nurse prescribing anyways, just because people often presenting to emerge have other medical or mental health issues going on that would possibly make prescribing outside of our scope, or at least requiring consultation. But yeah, maybe with more experience in that specific environment, the comfort would grow. There's definitely a need in the smaller communities, like you say. In Vernon, we have only one addictions medicine physician that works 4 half days a week to serve our community of 60,000. So,
Kyle, do you do much virtual care in other communities?
most of the work I do is right here in town. But yes, we do. I've done virtual to some of our supporting communities like Armstrong, Enderby, Lumbee, Cherryville, and even as far as the Queen Charlotte's for folks if they're away for work. So.
Oh, cool.
Okay. So Verena has also mentioned that there's definitely, an increased capacity at some of the community mental health services. For sure. Yeah, lots of opportunity there for integrating nurse prescribers.
The Vernon Clinic where Kyle works, like maybe I'm going to sound like a broken record, but their model, like the way they have it structured is pretty fantastic. They have an ops site there, so they have an overdose prevention site there. They have their ICM team works out of the office. You've got Kyle and Sam, is Sam a nurse prescriber as well? Yeah. So they've got 2 nurse prescribers. Then they have the OAT doctor that comes in. They've got a pharmacy next door that they partnered with that collaborates with them. Like it's a really great model of care. And I think, yeah. And so I feel like I don't know if the community clinics in Vancouver are like that, but I feel like Vernon has it dialed in, and it's a really all-encompassing like wraparound model of care that catches a lot of people.
I know in Vancouver, we have more recently have nurse prescribers working with the overdose outreach team and working really closely with the RAC at St. Paul's Hospital and the clinical team at Access Central. And so that's been a really amazing partnership because they're also supporting. So now if clients are phoning Access Central requesting withdrawal management services and they're not on OAT, or there's a gap there, they need to be titrated, the physicians will write the prescription. All of the care is by phone, so there's no Zoom or anything like that. And so it would be very limiting for nurse prescribers, the work they could actually do at Access. as is, but the physicians will definitely prescribe OAT and then indicate in their note that the nurse prescriber is with it, that they can follow up with the client in the community. And so then OAT nurses will connect with the clients, and are they able to do outreach, meet folks in pharmacies, and they also will follow up if for missed doses and things like that. And then part of the work is just like with that team continually trying to connect people to a longer term OAT provider and clinic and that kind of thing, where they can receive OAT and then other care that they might need as well.
I love that they're
Yeah.
partnered with the OOT team, because I think that's really, really cool.
Yeah, it's awesome. All right, and then there's another question from Shyla. Just curious how nurse prescribers on the call, or what their experience is with other healthcare professionals with the increased scope. If they feel like, I guess this is for Kyle, like if you feel like your expertise is being recognized, or other nurse prescribers on the call can jump in as well.
I'm happy to speak to my experience. I'd also be happy to hear from other nurse prescribers for sure in other areas. Certainly, I feel like our expertise is being recognized, sometimes probably too much so, to the point where I've had calls from emergency rooms physicians looking for guidance around a client that's been admitted. And I, at that point, will just have to defer to, the BCCSU 24/7 line. But yeah, I feel like we're really well received in the community. There's certainly a need. And yeah, we're here to help fill it within our scope. So
Great. Yeah, thanks so much for sharing. And yeah, Shyla's just got a comment here that I love that that's your experience. Yeah, that's really exciting to hear. Was there any more comments or questions coming from the group? Any other experiences with nurse OAT prescribing that anyone wanted to share? All right. Wow. Yeah, so please reach out if you think of any other questions that you want to ask. And it was so wonderful meeting with you all today. Thank you so much, everyone, for joining, and all of the comments and questions and engagement. And thank you so much, Kyle, for joining us today. It's really, really helpful to hear, firsthand what your experience has been and all of the exciting work that's happening in Vernon. And thank you so much, Lisa and Amelia, for all of your amazing work and dedication, and putting together this wonderful presentation for us today. So thank you so much, everyone. And I hope you have a wonderful day today. All right. Take care, everyone. We will see you next time. All right. Bye, everyone.